really we have to focus on the person. That's the model of care. Let's not focus on the disease or the change in behaviour. Let's focus on the person. We need to understand the condition, the multiple diseases that are dementia. But what we really need to be focused on is that person, because if we do, we can provide great care, we can extend and improve their quality of life, and we can delay the progression to final symptoms of this condition.
Welcome to the Unicorns podcast. I'm your host, Justin Kelly. Today we're talking about one of the biggest health and social challenges of our time, dementia. Right now, about 500,000 Australians are living with dementia, and that number is predicted to double by 2050. It's a condition that touches not just those diagnosed, but also families, carers, and communities across the country. At the centre of Australia's response is Dementia Training Australia, a national consortium funded by the federal government and led by the University of Wollongong. Its mission is clear: to transform the way we understand, train for, and deliver dementia care. From free online courses to specialist programs for health professionals and carers, DTA is working to build a dementia-aware nation. My guest today is Dr Isabelle Meyer, the Executive Director of Dementia Training Australia. Isabelle brings a wealth of experience across health, academia and community engagement, and is leading the organisation through a time of major reform. In this episode, we'll be talking about the scale of the dementia challenge, the gaps in training and support, the opportunities for innovation, and what gives her hope for the future of dementia care in Australia. Isabelle Meyer, welcome to the program.
Thank you so much for having me.
Tell us, let's begin. What is Dementia Training Australia and why was it established?
I think we're one of Australia's best kept secrets, Justin. We've existed for around 10 years now, and the organisation actually has a life and a history before that even. The successive Commonwealth governments have been really committed to the idea of funding dementia education in Australia for the health workforce. We know that, for example, nursing degrees, GP training doesn't actually include anything about dementia as a prerequisite in undergraduate or even graduate degrees. And so what that means is that there's an incredible gap in the curriculum for the health workforce in Australia. We know that dementia patients are approximately 80% of the bed block in our hospitals, and our staff in hospitals don't know how to manage that. We also know that half of the people living in residential aged care in Australia have dementia or some other form of cognitive impairment, and the staff there don't know how to manage that. And as our health system pivots more towards keeping people at home for longer, which is a great thing, we don't have the trained workforce to be able to deal with that. So we've been on a journey with successive governments for over a decade now. We're made up of 5 universities and one of Australia's major advocacy groups, and we develop curriculum and we advocate for dementia education, and we train and train and train some more.
And you were doing some of that today?
I was, yes. I had the privilege of joining a group of physiotherapists, allied health professionals, psychologists, and I was doing a series of webinars for a number of different groups today to help them on their dementia journey as well.
So, Izzy, who are your primary audiences?
Principally, we are funded out of the aged care budget to assist with the development of skills for the healthcare workforce. Now, that's paid and unpaid workers who are providing support for someone living with dementia. It also includes clinical professionals, enrolled nurses, registered nurses, GPs, and allied health professionals as well. We also have responsibility for offering training to those who might be regarded as sitting a little bit on the periphery of the health workforce. Paramedics and policemen and SES officers. So we train anyone who's going to have a touch point with someone living with dementia, whatever the care setting, whether they're living at home, in residential care or in a hospital.
If we take a step back just for a moment, what was it that first drew you into this field, and how has your professional history helped shape the vision for Dementia Training Australia?
Big question. I think that my own journey to this role has been a pretty eclectic one. Mm-hmm. I don't ever describe myself as actually having a career path. I have a wild ride. And it's
Very
been
good.
a wild ride.
Yes.
I have an academic background that covers sociology and literature. And a great many other things as well. I have a clinical qualification, and I also have some qualifications in mental health. So I've covered quite a lot of different roles: advocacy roles, education roles, work in policy and work in service delivery in the health sector and other places. Coming to this role, though, was a very personal thing. Like 1 in 4 Australians, I have a touch point. I have family members, and I also have some close friends who have dementia diagnoses. I have 2 grandparents who died of dementia. So my own knowledge and experience of what it is like to live with this condition has been really shaped by decades and some generational experiences. I grew up in very far north Queensland, up on Cape York actually. We lived in country towns, tiny towns, and when my grandparents were diagnosed with dementia, the kind of care they received, the options that they had for health were incredibly limited. A few years ago, a friend of mine was diagnosed with dementia just at the point of his 60th birthday. He lives in Scotland. The experience that he and his family had of what care he could access, what support he could access, the amount of time he was allowed to continue directing his own care and living at home was such a vastly different experience. I wanted that for the rest of Australia. I wanted that for the people that I know and care about. So when I was offered the opportunity to consider this role, I think I hesitated for about 0.3 of a second.
Yes.
Took a pretty big pay cut, I might say, but it was well worth it. I have an extraordinary team, really dedicated and really focused on what they're doing. And I think where we've been in the last 2.5 years is evolving not a new or radically different mission from the way it was before, but a new focus and a new imperative about how quickly we need to get our training products to market, expanding our reach and expanding people's knowledge of us so that they know to come and find us when they need something.
Yes. So as Executive Director of DTA, what do you see as your biggest leadership responsibility in changing how Australia approaches dementia care?
I think making people aware that some of the myths that we all grew up with about dementia aren't real, and that there's real training based on good evidence and good clinical theory that is available, and it's, thanks to the generosity of the Commonwealth Government, available for free. So my challenge is very much about how do I make sure that every single Australian knows that DTA is there and can help. And that's really been our focus.
Australia is on track to nearly 1 million people living with dementia by the year 2050. So what does that mean for our health system and for communities more broadly?
We're already there. And now we know that in Australia there's 440 odd thousand people with a diagnosis, depending on how you count the numbers. But we suspect that the number of people already living in Australia without a diagnosis would push us pretty close to the 1 million people already.
Really?
And that's going to double. We know that. What we also know is that in Australia, we are not just because we're getting better at diagnosis, we're finding more and more people developing dementia earlier and being diagnosed a little bit earlier if they're lucky and able to access treatment. But the game is really changing. It's not a disease that's about what happens to you when you're really old anymore. The bigger cohort, the growing cohort in Australia of people with a diagnosis of dementia are in their 40s. And if you have other chronic illnesses or other conditions, it might be even earlier than that. So the tsunami that's coming is not just about the numbers of people with dementia, but who they are. And the other challenge that we have in Australia is where they are, because our ability to reach and provide diagnosis, to provide support so that people can stay at home across Australia is really uneven. So the other part of my mission as Executive Director has been to extend our reach as far as possible into regional and remote Australia. Because I think the thing about being cared for at home for as long as we possibly can is just good medicine.
Yeah.
In terms of where we need to be with the health system overall, building the capability and the capacity in the health workforce so that people aren't afraid of this as a condition, that they know as clinicians and as carers it's okay and they can manage it and they know what to do and they know how to respond, because it can be a really confronting thing. Those are really important things. We already have a disproportionate number of Australians with or without dementia who are occupying hospital beds who shouldn't be in a hospital bed. The more we can build the capability and capacity of the health workforce overall to not have people in hospital, great. And how we manage care for people living with dementia is a very big component part of that.
You touched on geography. I'd just like to drill down into that ever so slightly. How significant is the gap between metropolitan and regional healthcare when it comes to dementia, and how do we begin to close it?
Let me give you a couple of examples. Last year, I spent a bit of time back up on my home turf on Cape York, and I was training in a community of about 1,300 people. They have a brilliant facility that's been provided by the Commonwealth Government. It's supposed to be staffed by 27 people. They have 11 staff because they can't recruit into this very isolated community. So that means that for people with complex illnesses, chronic disease, they're needing to fly because the roads are only open for about 5 months of the year to another town. If they have dementia and they need a diagnosis, they need to go to a memory clinic or see a gerontologist. The nearest one that they can access, given waiting lists and other things, is nearly 1,300 kilometres away. People tend not to go on those long-haul flights to visit a doctor, largely because they're also really terrified that they'll never get home again. And as it's a largely, not completely, but largely Indigenous community, the idea that they would be banished from their country and not come back is too heartbreaking and too terrifying to contemplate. It's not, unfortunately, uncommon. There's lots of Australia where you're talking about people having to go thousands of kilometres for diagnosis, let alone treatment. And that's not limited to dementia alone either. If you have certain kinds of cancer in Australia, if you need advanced care for diabetes or kidney failure, you will face exactly those circumstances. having to drive hundreds of kilometres to access medical care. We are a tiny population on a vast landmass.
It's true.
And managing that is really hard. So our health system's already under a lot of pressure because of our geography. What I will say to you is that I have observed some extraordinary GPs, nurses and carers in regional and remote communities. But their ability to support their families, lead their lives, stay in those communities is itself pretty limited. So we find ourselves in circumstances where, as a system, it's a real challenge for us to have the right people in the right place so that everyone can access care.
So on that, how well prepared is our health system and our healthcare workforce to handle the growing number of people living with dementia?
It's getting better, I'm pleased to say.
Good.
But we still have a long way to go. And one of the things that Dementia Training Australia is really focused on is training as many trainers as we possibly can so that we can reach further into the workforce, particularly into the residential care workforce, and keep the training going. We train between 32 and 54,000 people a year, face-to-face and online combined, but it's not enough. We're not hitting the sides.
Yeah.
So training trainers who will take that knowledge back into their organisations and keep it going is really important. And we've got some terrific pilot programs happening in acute care and residential care all around Australia. So we're moving our way forward, but it is going to take us a while. And the government is currently considering where to from here with its workforce strategy as part of the National Dementia Action Plan.
Can you paint a bit of a macro picture for us? For example, if you were to look overseas, what is considered best practice here? And are there models or approaches that Australia can learn from?
Oh, I think we can always learn from each other, but I will say, excuse me, a bit of a proud moment here.
Yes.
We lead. We lead on the creation of the National Dementia Education Training Standards Framework, which has been endorsed by the World Health Organization. There are a couple of other standards frameworks that do exist worldwide. They're a little elderly now. One comes from Ireland, one comes from Scotland. World Health Organization has endorsed ours.
Isn't that fantastic?
Yeah.
Yeah.
Yeah. There's lots we can learn around the models for residential care in Australia, and Europe leads the way on the concept of dementia villages. And in fact,
what are dementia villages?
So they're a really interesting idea that's been around for a couple of decades now, where as part of assisted living, you create a safe space based on the actually aligning with the national design principles that the government launched last year that enable people to live in small cottage-like facilities within a secure environment, great wayfinding that's picture-based. They can walk where they need to, be safe. They can access other facilities such as shops and other things in a village environment. But it's been designed to take into account the vision impairment that people with dementia often suffer from, and also their challenges around communication and problem solving. So it's an enabled environment. There's some terrific examples that exist in the Netherlands and throughout Scandinavia. And we're on our way to exploring what we might do here in Australia. That as a model for residential care is an absolutely terrific one. And I think the Canadian experience also is pretty exceptional in terms of the way in which they link dementia care and planning for dementia care to ongoing palliative care, and assist people to remain at home or in a home-like environment for as long as they possibly can. So we're learning all the time. There's lots of good stuff all around the world, but I think we stand up and make our contribution.
So why is continued training so important, not only for healthcare professionals, but also for carers and the wider community?
I think for two reasons, Justin. First is the research and the evidence base for what we're doing and what we know how to do, or the sorts of responses we have, is changing all the time, and it's getting better all the time. 20 or 30 years ago, the standard response to changes in someone's behaviour would have been to put them on antipsychotic medications. We now know that that is absolutely the wrong thing to do, and that there are only really very exceptional circumstances where you would medicate in response to changes in behaviour for someone with a diagnosis of dementia. I'm not saying it's wrong, but I am saying that Australia, according to the World Health Organization, is 11 times more likely to oversubscribe antipsychotic medication for people with a diagnosis of dementia than anywhere else on the planet, and that can't be a good thing. We also know that a lot of the drugs that are prescribed just don't work. So why do we do that? As our knowledge gets better, I think we need to be refreshing what's in our practice, what's in our toolkit for managing it. So first reason would be the knowledge is getting better. We need to be refreshing our knowledge. The second thing is the experience of training itself. As somebody who's done an enormous amount of teaching in my time, but also someone who's sat in classrooms and done an enormous amount of learning in my time, we all learn differently, and we all need that experience of learning something new and learning it in a different way, because it reinforces what we already know, and it also provides us with a really important marker in developing our own resilience.
Yes.
And there is nothing like the care of someone with a diagnosis of dementia, particularly as the condition progresses. That resilience, that emotional wherewithal to look after yourself as well as look after the person you're caring for is really important. And our training can provide that marker for what do you do to care for a carer. And that also is a really significant part of the training that we offer.
So, Izzy, are there knowledge gaps that you're aware of? And if so, how are you, as the boss of DTA, trying to lead your organisation to close those gaps?
Yeah, there definitely are gaps. I work really collaboratively with some extraordinary experts from around Australia. The 5 university partners that make up DTA are people who are far more talented, knowledgeable and gifted than I. And what they bring to the table is a wealth of knowledge and experience around specific areas of practice. Some obvious ones are around wandering, for example. And our colleagues at QUT are doing an incredible amount of work at the moment as part of some research and also some curriculum development for us around how to respond to somebody who needs to be mobile, who's involved with activities. Sometimes they are a result of stress or anxiety that they feel they need to be somewhere else. Sometimes it's actually that they're replaying a past experience, and sometimes we're really not sure why it is that they want to move repetitively or go for long walks. And none of that ought to be a bad thing, but we need to get better at knowing what's the unmet need here.
Yeah.
So that's one example of some of the work we do. We're also as we get better clinically at understanding what's going on in the brain and what the changes are likely to be, we're able to target specific areas. Like most people with dementia in the later stages of their illness will experience difficulty swallowing. They'll have irregular heartbeats, they'll have sleep issues, particularly if they have Lewy body dementia, where the body doesn't make melatonin anymore, can't get into a REM cycle, and people wake up every 75 minutes screaming their heads off. You know, there's a dinosaur chasing me. As we get better at understanding the impact on the brain and what's happening as a consequence of those changes, we get better at what's the practical way of alleviating that stress, managing that anxiety, and therefore managing the behaviour. I think for me, the profound lesson that I've learned, that my staff have taught me, and that the people I know living with dementia have taught me, is that really we have to focus on the person. That's the model of care. Let's not focus on the disease or the change in behaviour. Let's focus on the person. We need to understand the condition, the multiple diseases that are dementia, but what we really need to be focused on is that person, because if we do, we can provide great care, we can extend and improve their quality of life, and we can delay the progression to final symptoms of this condition.
So how do you measure the impact of the training programs, and what evidence tells you that these programs are making a difference?
So we actually have a suite of measures that we impose on ourselves. We also have some very strenuous reporting requirements back to government every 6 months. And we report as part of the National Dementia Action Plan into the Australian Institute of Health and Welfare as well. Some of the measures that we use are around the satisfaction of the participants in our training. Do they feel they've learned something, and are they going to apply it? We also look at some more indirect measures, which are how many times do people come back to us for more?
Yeah.
That being an indication that what they got the first time really worked and that they want more. So we look a lot at our user patterns, at our repeat customers. And in addition to the evaluation markers that we impose on ourselves, as I mentioned, the Institute of Health and Welfare is always checking on what's the impact of training. Are we moving the dial on diagnosis? Are we moving the dial on longevity? Are we reducing drug rates? That's something the Safety and Quality Commission looks at. Are we reducing the number of incidents of severe or traumatic behaviour or even injury? Safety and Quality Commission, again, is looking at that. The government's imposed on us and on providers around Australia some very stringent measures around what needs to meet the standard of the new legislation, and it is measured very carefully.
What role is technology playing in dementia care? And in particular, we all hear about AI, but also virtual reality and just other tech platforms that might not have been around a few years ago that are now making a big difference.
Yeah, it's interesting. My last trip to Europe, I spent a bit of time in a number of different aged care facilities, all of whom are using robots to deliver the afternoon tea.
Really?
And also the robots all have monitoring and sensors in, so they can detect if someone's levels of anxiety or distress are increasing. They are monitoring the residents. They are assisting with menial tasks, robot vacuum cleaners and all the rest of it buzzing about. So there's quite a lot of technological enablement for domestic environments that actually can overall reduce the amount of time a carer spends on those sorts of tasks, thereby giving the carer more time to have one-on-one interaction with a person. There's not quite so much of that in Australia. We use virtual reality, we use a lot of gaming technology, we use a lot of animation to make sure that our training experiences are quite diverse. Not everybody learns the same way. We also use a lot of that technology and assistive technology in particular to assist with translation. Whilst interestingly enough, one of the evaluation surveys we did was around delivering all of our training in English, because we know that that doesn't necessarily match up with the profile of the workforce in Australia, particularly for residential carers. However, what was really interesting was that over 78% of the respondents said they wanted to train in English because it was about reinforcing English as the primary language in which they had to do their reporting and operate in their environment. However, we use a lot of AI to assist with translation when we need to.
Yes.
We use it to also make sure that we can screen quickly and get a product to market once the academics and clinicians have finished with it, to make sure that we've not inadvertently done anything that was culturally inappropriate or insensitive. We use a lot of animations because for some cultures showing living images of people who've passed is not appropriate. And as our training is about practical skills, there's a lot of demonstration that happens. So we do use a lot of those sorts of technologies as part of our teaching and training and part of our development work. We're actually putting together a program at the moment to train staff in how to work with assistive technologies, particularly some of the diagnostic aids that are being widely used in North America and Europe. So that course we're hoping to have finished in a few months' time. It'll be interesting to see what the uptake is. I think in the hospital space there's a lot more comfort about using assistive technologies, but certainly in residential care at the moment there's not a huge amount of that being rolled out in Australia. It will come because I can
inevitably.
Yeah, and look, I don't think it's all bad. I actually think anything that takes away menial tasks and gives a carer more time to be interacting direct with someone, the better that is.
Let's put your policy hat on just for a moment. If you could influence one major policy change to transform dementia awareness in Australia, what would it be?
I've been thinking a lot about this one. One. Don't limit me to one. I've got about 10.
Well,
okay?
let's go. Rattle them off. What do we need?
I think if I had to distill it down, we honestly need to be acknowledging the significance of dementia as an issue for our health system. And I don't know that we quite do yet. Now, I'm a former academic. I know that changing curriculum in a university degree or even a certification is a complicated and time-consuming thing. And I'm not objecting to that because I actually think there's rigour and purpose to taking your time and getting it right. But we move too slowly on this stuff, and dementia needs to be in there as a mandatory thing. The impact on our health system overall by not managing this is disproportionate to the number of people that have it. Now, we are a long way from a cure. We're a long way from a vaccine. What we have is the benefit of diagnosing early and getting people the right kind of management so that we can slow the progression of the condition. That's what we have. And we're not enabling ourselves to do that well because the knowledge about what dementia is still quite partial and quite limited across the system. So more training by DTA will help, But at the end of the day, if we're not getting the doctors and nurses earlier as part of their formal training, we will be tying one hand behind our back in a systemic sense. I think the current government has taken incredible strides with the implementation of the new Aged Care Act last year. I know there was a lot of controversy about that, a lot of criticism. I'm not going to talk about that. But from a dementia perspective, we moved such a long way forward. I'd love to see us keeping up the momentum. And the next big thing needs to be that we set a minimum education standard for people providing care. You have a framework. You have the standards that you need. We need to be actually making sure that people understand how critical and important this is, and that we need to be following through on a minimum standard of education.
And so what is it that gives you hope when it comes to the future of dementia care in this country?
Every single time I walk into whatever kind of classroom or gathering space, I see people who are there hungry to know how to do this well. And it is that commitment, it is those people, every single one of them. They're not there because they're being forced to attend a training course. They're there because they really want to get good at this. That's what gives me hope.
A final question to you, Izzy. Let's look ahead. What's on the horizon for Dementia Training Australia, say over the next 2 to 5 to 10 years? What does that look like?
Okay, so at the moment we are very much a creature of government funding, and the government has some decisions to make about what funding into the future looks like in line with their actions under the National Dementia Action Plan. So our funding is actually under review in the next 12 months. So what that looks like in terms of what's the government's commitment to continuing to resource us to deliver training, and what might be the options for us not only to seek alternative sources of funds, but also to broaden our brief in terms of building not just capability within the existing health workforce, but how do we help build capacity overall? The evidence is that for a lot of people, they don't stay in caring roles in the health sector because they don't feel confident about their own abilities. So one of the things that we've been very focused on in the last 18 months or so, and that I'm hoping we will continue to build forward, is leadership programs, and a lot more of that building resilience and building commitment within the workforce, and making this a career, making dementia care a career for people in a way that I think it sort of is a little bit of a niche, but it's not quite there. And we need this to be mainstream. So what I would like to see on the horizon for Dementia Training Australia is that we're working really hard to create that generation of leaders and to create the idea of being a dementia carer as an exceptional career for anyone in the health workforce.
Dr Isabelle Meyer, wonderful insights today. Thank you so much for coming onto the program. It's been great to spend some time with you, and I'm sure the audience will agree that was a terrific episode. So thank you so much for sharing your professional journey with us today.
Thanks so much for having me.